there, this is Dr. Evan Osar, founder of Fitness Education Seminars, the movement-based solution to the healthcare crisis. Thank you so much for tuning into this webinar series on corrective exercise solutions. In this edition, we're going to continue our discussion on corrective exercise solutions by looking at a very key region to the function of the low back, pelvis, and the entire lower extremity. Later in this webinar, I'm going to discuss a resource you need if you are looking to become a specialist in corrective exercise and help more of your clients achieve their health and fitness goals. So let's get started. What do we know about gluteus maximus function? One of my favorite poets is Ralph Waldo Emerson, and he said, "I wish to say what I think and feel today, with the proviso that tomorrow perhaps I shall contradict it all." And in the beginning, I was part of the problem. In fact, I taught my clients to squeeze their glutes for all they were worth, and I had them performing exercises not too dissimilar to what I'm demonstrating in this image to the right. Over the years, I got a little smarter when I actually noticed that more of my clients actually had more hip dysfunction by some of the very cues and exercises I was giving them. So what I want to share with you today is some of the challenges we have with the cues and the exercises we are using with our clients, how they're actually leading to some of the dysfunction we see, and how they're actually leading to some of the more pronounced dysfunction like hip degeneration, and are actually a cause of a lot of hip pathology. And I'll show you a strategy to improve how you teach your clients exercise, the cues you give them so they can achieve their health and fitness goals. But first, let's talk about one of the biggest myths surrounding the glutes. And one of the major ones are people have weak gluteals. We tell that all the time, we hear that all the time in all the seminars, and we train it and preach it over and over and over again. And unfortunately, that's a myth. So what is the real problem that our clients have? Well, the biggest problem they have is they have poor motor control. They have poor motor control of their core, they have poor motor control of their hips. Therefore, that translates into what we perceive as weakness of the glute max. And we think that we should teach them how to over squeeze the glute max and perform glute max exercises until the cows come home. But unfortunately, what we're seeing with many of my patients and my clients is that hasn't helped them at all. It's actually made them more dysfunctional. And we'll talk about a little bit of the anatomy surrounding the hips, pelvis, and low back so you can understand and appreciate why this is actually true and how motor control relates to function of the hips and actually more dysfunction. First, let's look a little bit about and talk a little bit about the glute maximus. One thing I do as a specialist in corrective exercise is I go to the sources for information. One of the key sources for glute max function is Sean Gibbons. And unfortunately, a few years ago, he was presenting in Scotland, and I could not make it because I was teaching that same weekend. So I sent my wife over, actually she was my girlfriend at the time, so I sent my girlfriend over, or my present wife, my girlfriend at the time, to Scotland to get the research from Sean Gibbons and see how he was training the glute max. And here's what she discovered during his seminar and the research that he's been doing. Well, there's three, maybe even four distinct areas of the glute max. The upper fibers are the iliac fibers, and those are the ones in red. They come off the iliac crest, and their function is primarily extension and abduction of the hip. There's also medial fibers or sacral fibers. So there's an upper and lower division of these fibers, and they also contribute to extension and abduction of the hip. Now here's the conundrum here, and here's actually where most of our clients have most of their problems. The coccygeal fibers come off the coccyx, and they also perform extension of the hip. But here's the key, and here's what I want you to focus on, is they also provide posterior glide. They actually pull the femoral head posteriorly in the socket. And that is a key function that's missing in many of our patients and clients that have gluteal dysfunction. And many of our clients that have hip pain, groin pain, and poor performance in their lower extremity actually have weakness and atrophy of these fibers. So let's take a look at more research from Alison Grimaldi. She's another researcher that focuses on the hip, and she did 2 studies on hip pathology. So these individuals had degeneration of their hips. So in the first study, she looked at the association between degenerative hip joint pathology and the size of the glute max and tensor fasciae lata. And what she found in unilateral degeneration of the hip both the glute max superficial fibers and the tensor fascia lata showed no change in size. What she did see, however, is the lower fibers of the glute max. So again, those fibers we just talked about a minute ago. So those coccygeal fibers are the ones that tend to atrophy. So those are the fibers that atrophy and do not help the hip glide posteriorly in the socket. She also looked at what happens between the glute medius minimus and piriformis. So she did another study looking at unilateral hip degenerative clients, and also noticed the size of the glute medius minimus and piriformis muscles atrophied in those clients as well. So again, these clients that have atrophy of their, or degeneration of their hip, have atrophy of their glute medius, minimus, piriformis, and the deep fibers, the deep lower fibers of glute max. And unfortunately, for our clients that we're training, many of them aren't using these fibers, and actually, in my patients and clients, especially the ones with hip problems, they have atrophy of the glute max way before, the lower fibers of the glute max, way before they have any symptoms of hip pathology. So it's a key sign to start to look for the lower fibers of the glutes when we're assessing our clients for hip function. A colleague and friend of mine, Diane Lee, another major player in the research and development of strategies to improve hip function, talks about butt gripping. And so many of our clients are actually butt grippers. I used to call it flat butt syndrome, but now I realize it wasn't just flat butt syndrome, but people are actually over gripping their glutes. So they're butt gripping, as Diane Lee suggested. And she discusses the pelvis as a pyramid. So you see the image on the right, the individual in the image there has a pyramid when the glutes are well formed and there's a roundness to the glutes. So we see here there's a roundness to the glutes, there's no indentation here, and the pelvis forms a pyramid. When the client over contracts their glute max, especially those superficial fibers, they get an inverted pyramid, and you start to see this hollowing or indentation. So this is a huge sign that our clients are using their hips improperly, especially the glute max. And this is something we want to look for as we assess our clients' hips. Unfortunately, some of the exercises, many of the exercises and cues actually lead directly to this butt gripping syndrome. And in the industry currently, hip thrusters seem to be all the rage, and clients just jamming their hips into anterior positioning in the acetabulum by over clenching the glutes. So you see me performing that in the image to the left, and you see me over clenching my glutes and at the top of deadlifts, and you see it with clients in squats, lunges, step ups, kettlebell swings. Clients are cued to over squeeze the glutes and drive the femoral head forward in the socket. And that creates this dysfunction where clients are overusing their superficial fibers of the glute max, underutilizing their deep fibers, and they're creating an anterior hip position, which directly leads to degeneration of the hip and early degenerative changes of the hip. And if you're training young clients and young athletes, and when I say young, I mean anywhere from 15 to 30, you can get away with this for a while, but wait till the clients are around 35, 40, 45 years of age, and you start to see the ramifications of these type of strategies. So how do you know if your client is a butt gripper? Well, some of our cues also lead to hip dysfunction. When we teach our clients to squeeze their glutes, as the client is doing in the image to the left, she's over squeezing her glutes, and you see her go into a posterior pelvic tilt. When we teach our clients to contract harder and or pack the hips, these cues lead to over gripping of the glutes. And we see the shape of the glutes and the indentation here. And again, the client's wearing black, so you don't see as much, but you can definitely see it in the image of this client here who presented with low back and SI joint pain. This client also has chronic low back pain. And you can tell she's over gripping her glutes here, and actually is also over bracing and over gripping her abdominals. So these cues tend to create more dysfunction in our clients when they're used with a poor strategy. So how do you know that your client is a butt gripper? Well, here's 3 signs. 1, they have a flat butt. They have no glutes. And you see this client who presented to me with low back pain. He's a runner, can't run anymore because of low back and radicular pain down his leg. And you see he's got no glute mass at all, except for right here. You can see, yes, he's got some superficial glute activation, but no lower glute and no glute medius, and very poor hip external rotator mass as well. So he's got poor centration, and if you palpate the hip in the socket, you'll feel it very anteriorly. What's another sign that somebody is butt gripping? Well, if you palpate the lateral aspect of the hips, so put your hands right over the greater trochanter area, you'll feel a divot or hollow there. You should not have a hollow there when you're just standing relaxed. If the client is standing relaxed and you feel the hollowing, you know they're over gripping with their glutes. It could be the superficial fibers of the glute max, it could even be some of the glute medius, because they've been taught to over grip with those hip muscles. Last sign is when the client sits, you're going to see lumbar spine flexion, as you can see in my patient here, who presented with also sacroiliac pain, hamstring issues, and groin issues. And you see when he sits here, he's got flexion of the lower lumbar spine and extension at the thoracolumbar junction. Even though he's been told to stretch the crap out of his hip flexors, he had over-lengthened psoas, over-lengthened hip flexors, and over-gripping of his glutes. So again, in these clients, they'll have low back pain, chronic hamstring and groin issues, and if you test their psoas, it's shut down, over-lengthened, and it tests weak. So again, we've talked about psoas in the past and how psoas is really not a hip flexor, it's actually a spine stabilizer. And again, this will lead to more of our low back pain, and that's why more of our clients, even though they may look like they're in an anterior pelvic tilt, they are not. They're actually in a posterior pelvic tilt, and they have thoracolumbar extension. We talked about that in a past episode, and we'll address it again in a future episode of Corrective Exercise Solutions. So what are we going to do about this? Well, first of all, let's look at a little bit of research and see what it says about the glutes and squats, for example. We talk about so much about knees behind the toes. So we look at a study that comes out of the Journal of Strength and Conditioning Research and the effective knee position on hip and knee torques during a barbell squat. So in the study, they say, yes, restricting knee movement decreases knee stress. However, when you do not let the knees come forward, that load is transferred to the low back. So again, if we keep the knees back, it may help our clients that have knee problems, but it's actually going to contribute to our clients that have low back pain. So we have to be careful how we are cueing our clients, even though we learned from the dawn of time, don't squat with your knees going over the toes. So we have to get rid of some of these cues for some of our clients, especially the ones that don't have knee problems currently. Here's another study. The effective back squat depth on EMG activity of 4 superficial hip and thigh muscles. So what this study showed is that the deeper you squat, so again, if you squat all the way down where your butt is touching your ankles, yes, you get increased activation of glute max. But here's a problem with that. Yes, EMG study shows that you have more activation. Any exercise that demonstrates or promotes more contraction of a muscle will show more EMG control. But is that actually a good thing? Well, not if you got a client that's got a disc issue. Not if you have that client that was in the picture I showed you earlier that had lumbar spine flexion. And most clients that sit for a living, they are in lumbar spine flexion. They are in posterior tilts. So the more you squat them to the more you perform deep squats with them, the more dysfunctional they will become. And the more you'll contribute and hypermobilize their lumbar spine, and you'll do nothing for their glutes except make them contract harder and harder and lead them to more and more dysfunction. And again, I don't care about your clients that are athletes and they have great hip flexibility. Those are not the clients I'm talking about. I'm talking about the general population clients that have poor hip mobility and poor spinal stability. Deep squatting will ruin their backs, and I've seen it happen time and time again. Squat clients to the depth of their control of their lumbar spine and the amount of hip flexion and hip mobility that they have. So another thing we need to pay attention to when we talk about the glute max is, when is the glute max most active during life? Sure, it works when we're squatting. We all know that. We bend forward, it decelerates us, it helps us get out of a low squatting position, low lunging position. But when we're walking, the glute max is actually most active when you're in the loading phase, or when this woman is stepping onto her forward leg and her right leg in this image. Her glute max is most active at loading phase. So when she loads her weight onto that right leg, the glute max is most active. And it's also most active in this eccentric roll of the hip coming forward. So it's a decelerator during quiet walking, or normal walking I should say, and it also is a pelvic stabilizer. So we have to think about those functions, not just its function in hip extension. It doesn't do hip extension until we do fast walking, walk up a hill, and or run. So we got to think about its eccentric function as well as its stabilization function. So the three primary functions of our glute max: hip centration. Number one, the key to improving glute and hip function is teaching the glutes how to become better hip centrators, how to control the femoral head in the socket. And if you pack, contract, squeeze harder, you are not helping your client centrate their hip. You're actually driving the hip forward in the acetabulum, unless you are palpating to make sure it's not going forward, and most likely it's going forward. Number two, it helps to stabilize the pelvis. So again, in single leg stance, during walking, during even single leg exercises, it helps control pelvic stabilization, or the pelvis over top the lower extremity. And third, it helps hip extension. So we're going to look at the best exercises to train these three functions. They're not the only exercises. They're not maybe even where I would begin, but they're three very effective exercises that train these primary functions. So let's get started with it, looking at those. Number one, centration and pelvic stabilization. The bridge is perhaps one of the best exercises to help teach centration and the function of stabilization function of the glute. In the image to the left, you can see the fact that I'm hyperextending through my low back, using my glute and actually driving my hip anteriorly. So what you can't see is you can sort of pick it up, the hollowing here, my hip is going anteriorly in the socket, and I'm hyperextending at that low back, not really even using my glute in an efficient manner. And in this image, now my hip stays better centrated, I have better control of my thoracolpelvic canister, and I want to think about my weight coming down this direction as I lift up, and I teach my client how to bend and hip hinge through their bridge. They do not and should not change the position of their thorax. They should do a hip hinge and teach the glutes to control this motion and not drive that pelvis into an anterior femoral position, which a lot of our cueing and exercise choices are doing. When we start to teach our clients to squeeze their glutes for all they're worth, contract harder, we're going to drive that femoral head forward in the socket and disrupt the normal axis of rotation. And that's one of the key things that leads to hip dysfunction, as we mentioned. The eccentric role of the hamstrings is to control the anterior pelvic tilt of the pelvis. So reaches are one of the most effective patterns to use to teach this function in our clients. So we can start with bilateral pattern, or I should say a parallel stance, but then also move to a split stance and just teach a client how to anteriorly rotate their pelvis with no change in their lumbar spine, or in their thorax for that matter, and no change in their lower extremity positioning. They just reach out and come back, making sure the motion comes all from the hip region and not from over squeezing and not from rounding the low back. Once a client has control, now we can teach them to go on one leg. And again, most clients will not graduate to that level unless you're working with pretty high level clients. If you're training athletes, yeah, you should probably train this function, or you need to train this function in your clients. For most of our general population clients, especially ones with hip dysfunction, they probably will not get to this pattern, but that's okay. If you improve a split stance reach, they're going to have dramatic improvements in their hip function. So again, this teaches against stabilization, centration, and eccentric control of the glute max and the entire posterior chain. Now, the third function, improve hip extension. Sled push is one of the best patterns to improve hip extension. Once you've taught your clients how to centrate their hip and eccentrically control the hip position in the socket. Again, we want to make sure that spine stays neutral, scapula stays neutral, and the client drives through the posterior hip without over squeezing and centrates the hip as they push the sled. They drive through the hips and they push the sled, maintaining control throughout the entire kinetic chain. It's a great, great pattern, both cardiovascularly and as well for conditioning the entire lower extremity and teaching stabilization through both the anterior chain and the posterior chain, as well as the lateral chain for that matter. So again, the three patterns, the bridge, the reach, and the sled push are very effective patterns for improving gluteal function once a client understands how to get into the right position. So conclusion, the glute max has multiple roles. The most important role of the glute max and the most important role or function we can improve in our clients is improve their ability to centrate their hips. We have to teach them proper cueing. Do not have them over squeeze, over contract, or pack their hips. Teach them how to lengthen through their hips. Teach them how to dissociate. Teach them how to anterior pelvic tilt. Teach them how to contract, but not to over contract. And you want to avoid over gripping, as we've talked about, because this is one of the biggest things that drives hip dysfunction. However, there is a time when you probably want to do some butt gripping. And this is one time when you butt for all it's worth. And hopefully none of you guys are bullfighters, but you know, being an animal lover, it's kind of cool to see the bull win sometimes. If you're looking for additional resources, I just released an in-depth manual, Corrective Exercise Solutions to Common Hip and Shoulder Dysfunction. In this manual, I discuss how the low back influences hip function, why instability and lack of thoracolpelvic control leads to hip dysfunction. Also, I cover assessment, correction, and strategies to improve hip centration, the things you need to do to improve function in your clients, as well as the keys to developing and improving hip function through the fundamental movement patterns. Thank you again for tuning into this webinar. I hope it has served you in your goal of becoming the specialist your clients need and want. If you're looking for more free resources, check out our website at www.fitnesseducationseminars.com. In the final installment, we will look at corrective exercise solutions to scapular stability and why Y, T's, and W's actually contribute to your client's shoulder and neck problems. Thank you. This is Dr. Evan Osar with Fitness Education Seminars. Have a great day and keep working towards becoming that movement-based solution to the healthcare crisis.